Okay. So, and I welcome questions. So please, if you have a question as we're talking, I'd rather you ask it as we're going along. If you hear something that you're questioning or you wonder. So I'm really going to talk a bit about quick overview so we're all speaking the same language about the disease, the current outbreak, and what we do to monitor travelers from these 3 countries where Ebola has affected them, and what we've done for healthcare facility and laboratory preparedness across Washington state. So again, and this may seem really basic, but I'm going to go through a little exercise that happened last weekend when, of course, I'm trying to get to a mountain bike race that my kid's racing, and it's on a weekend, and, you know, and we'll walk through this because we all thought everything was so nicely put into categories, and then we get a curveball. And it still comes back to these basics about everyone has a lot of fear about Ebola. Yet we know the science about this, but we tend to forget when we get a little excited. So a reminder, it's a virus. It's not a bacteria, it's a virus. It has to live within a human cell, so it can't live. Viruses don't live at all, right? They're not a live thing. They're just little pieces of protein. It can't just live on a table. It has to be in body fluid. It has to be exposed to your healthy living cells to get in and cause an infection. We've known about Ebola since the 70s. This is not a new virus to us. It may be a new virus to the general public in the United States, but it is not a new virus. There's multiple species, and we know that humans are really not meant to be infected by Ebola virus, that bats are the likely reservoir, and it occurs in these animal hosts in Africa. So why are we so concerned about Ebola here? How many cases of Ebola have we had in Washington state? How many people died of the flu in just the last year? Over 100. Why are our perspectives so odd on this one? Why are we so concerned about this? And I'm going to talk to you about a multi-million-dollar grant that we're actually getting for this, for 0 cases. All right. So we know that this virus lives within bats. It's when this bat gets into the animal population in Africa and then gets into the human population. And it's really just the ideal setup to spread, because what happens is as we encroach on forest land and we eat animals that we normally wouldn't eat, because some areas of the world are so poor they have to eat these kind of bush animals, it gets into a family, and what happens when a family member gets sick? Everyone takes care of them. What a great way to be exposed to blood and body fluids. So entire families in West Africa get wiped out. This is why this virus has really spread. Amongst other things, symptoms. And I know this is so basic, but I'm going to bring it back to you when I bring you this exercise we went through last weekend. Symptoms with Ebola virus are fever. And there's been a lot of debate about what is a temperature. Is it 100.5? Is it 101.5? What is the definition of a fever? This was the initial definition of a fever. What are you all using for fever definition? (101.5)? Oh, this becomes such a point of contention when someone comes into the emergency room, they've been in Liberia, they have no risk whatsoever, or let's say I've got a lot, well, I'll tell you what, I've learned a lot about the geography of Africa in the last 6 months. I've learned a lot of the poor education of the American healthcare system on geography, where people are freaking out about people from Kenya, 3,000 miles away from West Africa, that have a fever of 99. Is that a fever? Okay, so I think this is one of the things we all have to be clear about. What is truly a fever? Well, this is the upper limit. It's very reasonable fever. Most pediatricians and infectious disease docs, we use 100.4, okay? 100.4. That's a fever to me. But to be real academic about it, some people run higher body temperatures. They run 100 degrees, and that's normal. So really a 1 or 2 degree rise in that person is a fever. And then you get in this whole debate, well, what if it's under the arm versus in the ear versus in the rectum or the mouth? Don't you subtract a degree? Get all this stuff straight within your own institutions before it becomes a real headache, which is the next symptom of Ebola. Muscle pain, weakness, diarrhea, vomiting, abdominal pain. I'm going to say this 3 times: abdominal pain, abdominal pain, abdominal pain. And I'll tell you why, because you're going to get it later. Lack of appetite. They can include some of these other really good for movie type things, like unexplained bleeding, Hollywood likes this, but this tends not to be the big presentation of Ebola. It tends to be these: the fever, the headache, the muscle pain, the vomiting, the diarrhea. So the reality of this is, and everyone asks, there's some science around this, that if you know someone is infected with Ebola and you draw their blood, okay, but they don't have a fever yet, the likelihood of recovering actual viral particles is next to 0. It's really hard to recover viral particles. There aren't enough virus in the body to be recovered until they've developed a fever. So when we tell people you're really not that infectious until you're febrile, that's based in science, but it's very hard for people to understand that. And I'll talk about that a little bit more. We know that it is spread through direct contact. It has to be exposed to broken skin or mucous membranes. So this means a sick person's blood or body fluids. Any body fluid you can imagine. Certainly things that will poke you or cut you that have been contaminated will do that. And infected animals, yeah, sure, if you're eating bush meat from Africa. But this simplification, here's the thing about Ebola, and when these are very complex science-based issues and we try and simplify them, you'll never be 100%. So never, people love black and white. And unfortunately, when you don't know a lot about a disease, you gotta be a little gray. So when the CDC comes out with guidance that says you can't get Ebola through the air, I guarantee you how many citizens wrote me an email telling me, well, what if someone had Ebola and they sneezed bloody fluids in my face? It went through the air, right? Aha, you need to correct that. Or you can't get it through water, but what if there's water in someone's respirations and they spray it on, everything. You can't get it through food, but you can if you eat bush meat. So there's all these nuances, but I actually do like that we simplify this to say you really can't get it through the air. You can't just be in a room where someone has Ebola and catch it, okay? You really don't get it through the water system. So then why have water treatment systems refuse to take waste from a hospital that's treating an Ebola patient? Is there any science behind that? No, the science is it does not spread in the water. And then of course you can't get it through food. So this is not the easiest virus in the world to catch. Measles, which you're all getting a taste of now, is. That's one of the most infectious agents. So the treatment, unfortunately, or fortunately, consists of supportive care. This is really balancing the person's fluids because they are losing up to 2 liters of blood or body fluids, vomit, diarrhea. And how good is that? How easy is that to do in a tent in West Africa, where you may or may not have the equipment? Or it may be 110 degrees out and you're wearing this personal protective equipment. There's no question why it's so hard to treat this. It might be best here in Spokane, you could probably balance the person's fluids and electrolytes and maintain their oxygen and blood pressure and treat them for any complicating. That supportive care is going to be much easier here in the United States. There isn't a hospital in Washington that really could not do that. Support someone's fluids and electrolytes, maintain their oxygen and blood pressure, and treat any complicating infections. Where it gets a little tricky, the rest of the world is not using these things, these experimental therapies that you hear about on the news. So when someone flies back from Africa, just to give you a sense of what the international community thinks of America around this one, if you're an American and you get infected overseas, you get special jet treatment back to the United States, to one of several facilities around the country, and you get something that may be human plasma from one of the docs that got infected initially, or you can get these monoclonal antibodies, which means they're genetically identical and they really target Ebola. But do the rest of the world get these? Do the folks in West Africa get this fluid? Do they get flown to the United States? So you can understand how this creates a bit of ethical friction with the United States, okay? So a lot of money invested here. A lot of my colleagues feel that we should invest all that money into West Africa. Okay? Just to be clear. So these Ebola outbreaks that have really gone on since the 70s, and the size of these outbreaks on this slide really represents relative size. And so the one that started in 2014 clearly has been bigger than the rest, but have really been only one of many outbreaks from Ebola. And when we talk about Ebola, just want to point out what a small piece of Africa we're talking about. And for those of you that don't know this, Africa is not a country, it's a continent. You may laugh, but some people still have trouble with this. And then West Africa, when we're talking about these countries, we're talking about Liberia, we're talking about Guinea, and Sierra Leone. These are the three countries that have had the most experience, and then Mali is here. So we're not talking about a West African from here, 3,000 miles away, being at the same risk of someone from these three countries. So the epidemiology of this virus is very important to understand when we're doing all the planning that we're going to talk about. Okay, so 25,000. This is the latest CDC guidance last night at 2 o'clock in the morning. So I wanted you guys to be totally up to date. Was 25,907 cases, the largest outbreak to date. 25,000, almost 26,000 cases, and a little less than half died. That's significant. There's been this widespread transmission in these three countries we talked about. We know that healthcare workers and close contacts of cases are at highest risk. So stop for a minute. Remember when this guy in Texas came into the news because he had Ebola? He had come from West Africa. Everyone's all up in arms about the nurses that got sick, right? Anyone stop to think, what about this guy's girlfriend? Did she get sick? Why not? Why do you think she didn't get sick? She was mopping up vomit and diarrhea and cleaning the house. None of the kids in the house or the apartment got it. So right there, it should give us some pause to say, what's unique about these nurses? What's unique about this virus? So it can't be that infectious, right? I'm not saying go out and just willy-nilly take care of Ebola patients, but put some caution to it. What was unique about these nurses was they were in an environment when this guy was so sick that his viral load was so much higher than when he was at home. And they're dealing with blood and bloody secretions and lots of diarrhea and a much higher amount of exposure than certainly his girlfriend was, okay? So keep that in perspective. There is these level 3 warnings that you really shouldn't be traveling to any of these countries. I have heard of every reason why people go to these three countries, and some of them are shocking. It's interesting, all the social things you learn about with an infectious disease. Like people that actually go over there, they fly on personal jets that come back through SeaTac, through Boeing, so they're not really known, and they are dealing with gold trade and all kinds of interesting trade, and very interesting. But the official travel notices are not to travel to these three countries, okay? And then when you come back, whether you're a traveler from the US or you're someone who has been in these countries, these three countries currently, you can only come back through 5 airports into the United States. So that has been a big debate early on, that the Americans should close our borders to anyone traveling from these three countries. I will tell you from an academic standpoint, closing a border because of an infectious disease has never controlled an infectious disease, ever. Show me the science where that has ever been helpful, and quite honestly, it's the opposite. It tends to encourage transmission when you try and close a border. But what the US did was tried to reroute these travelers through 5 airports. So they are asked when they leave any of these three countries, they're asked basic questions like, what is your risk factor for exposure to Ebola? Did you take care of a patient? Did a family member have it? And they are asked that when they leave, and they are having their temperature taken as they leave those three countries. And so do you think they all have the same definition of what a fever is before they leave? They should, right? At this point it is. Then they come into these 5 airports. They're all on the East Coast. There are no direct flights into Washington State. You cannot fly from West Africa into Washington, okay? You have to fly into these 5 airports. They're all on the East Coast. And then what happens is they are then asked the same questions again. What is your risk exposure? What are your symptoms? And then they take their temperatures taken. That then goes into a database that gets sent to the state office. So I receive this sometimes every 6 hours, so multiple times a day, all times during the day. And they tell us the person's name, they give us their cell phone number, a backup cell phone number, an email and a backup email when they're coming into CTAC, okay? And they give us the county they're going to and their address, and we are to make contact with them to make sure they're monitored. Okay, that's the system that's gone on. They're given this thing called a care kit, which is a thermometer and how to get a hold of your local health department. And we'll talk a little bit more about that. But that information is done in real time. So we contact all the local health jurisdictions as soon as we hear about this travel. So let me remind you, in Washington, we follow the CDC guidelines. We go by this risk categorization, which is called high risk, some risk, or low risk, and you can look at the specifics in there. High risk is obvious, direct contact with an infected body fluid. We have not had a true high risk traveler into Washington State. Most of ours are either some risk or low risk. So this is a person who has worked in West Africa and they wore appropriate PPE. They go on this thing called direct active monitoring, which means the health department contacts you, usually in person the first time, maybe 2 times, and then twice a day your temperature is monitored, and depending on how the local health jurisdiction does it, it could be done by Skype or in person. We're asking you what your symptoms are, and then only in the high risk are we restricting movement, okay? So, by the way, quarantine or isolation are terms that really are not what's happening here. We are not quarantining people in Washington State. We are restricting their movement, but these people are not routinely at the some risk, are not routinely restricted, okay? They are driving. We are asking them to stay off of public conveyance. We are asking them to report their symptoms and their fevers. And you know, something that shocked me that I've learned from this is sometimes people lie. I was shocked. So the system is built to look at every traveler coming back, and do people get around this? And the answer is absolutely. There are people that fly from West Africa to Paris, stay for 3 days, fly to Brussels, stay for 3 days, and then buy an airline ticket back to CTAC. Okay? And then they don't say, hey, look, I've been in West Africa, and by the way, I got a fever. So now that we know that, that's called a broken itinerary. Customs and Border Patrol does that in all our airports. Looks very carefully where you have come in the last 21 days. Okay? So that's our current system. So where are we in Washington State? How many people have we actually monitored? So we have actually monitored, and I just got an update an hour ago. We're now up to 205 people have been monitored since September. So these are 205 travelers that have come from those 3 countries that have been monitored by local health jurisdictions. And I will tell you the majority of this is being done by Seattle-King County. That's who's doing the most work. That you've had 9 in Spokane, 1 in Lincoln, 1 in Okanagan, and 1 in Stevens. Currently, we just added a couple. We're up to 12 on the list being monitored today that actually got checked in today. 12 people are being called and checked. And we've really only tested 1 person for Ebola, who was one of these travelers who developed fever, okay? So it's a lot of work, 200 and some travelers being monitored twice a day for 21 days for very little yield. And again, we've had no Ebola patients in Washington. But this, yeah.
Any way to tell how many of these are involved in the military, because early on the military was mobilized and now people coming back?
Yeah.
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 Before you answer, can you repeat the
question, so that.
Oh yeah, sorry. For those of you on the thing, the question is how many of these 205 that we're talking about were associated with the military? And I think the bigger question that, and I'm going to pretend you're asking this, is how did the military interplay with us, and did they do a good job, and they monitor? And the answer is yes. This includes military folks, and the military has been very good on sending people there. They don't have a lot of people doing direct patient contact. They have a lot of support around building facilities and infrastructure stuff, so we've had none of them be a risk. They've all come back. The military has a very good system for providing a place for them to live for 21 days because it gets a little weird. I don't know if what experience, and we'll talk about that today, you've had with this dozen or so folks in your region. How smoothly has that gone? I will tell you, one of the military folks came back, lived in Thurston County, was clearly identified, clearly low risk, clearly being monitored, clearly had a place to go, and the school system sent out a letter to all the parents of every kid saying, by the way, we wanted you to know there was an Ebola dad that's in your school district. Now, think about it. It's funny, but why did we do that? Why did the school do that? Why would a school do that? Okay, back up a bit. This guy who traveled is low risk, and he does not have a fever. So can he transmit Ebola? No, that's the science, right? So why do you freak out parents by telling them the kids, they have nothing to do with Ebola, that your kids are around, have a person that has an infectious disease? I just don't find that very helpful. The military does a great job. I think the civilian side has a little bit of work to do to, tamp down the rumor and the fear. Quite frankly, as an infectious disease doc, we fear new diseases. We do goofy things when we don't understand them. TB, perfect example. Ebola, new things. So I'll be really clear about it. While I'm kind of poking fun at that we had no Ebola cases, what I think the value of us here today talking about this is to prepare for the next disease. So let me just finish a couple things here. I'm trying to tell you logical ways to think about Ebola, how to monitor for Ebola, and how to assess, and we'll get to that. But there's some real special skills. When I said there's nothing unique about the treatment for Ebola that any hospital couldn't do in Washington State, there are some skills that you need to have. How do you handle the media? How well do you interface with the military who has family members? How do you have a good employee health program? How do you interface with your local health jurisdiction, your media? Can you handle the media? So let me give you a very specific answer or scenario. We have avian influenza in Washington State. Okay, we have bird flu. We have the scary bird flu that you hear about killing people in Asia in our birds in Washington State. We're the first state in the nation to have those. What happens, by the way, we've had, even though it's named the same as the scary bird flu in Asia, it's a totally different bug. It's just named the same. Sorry, the H5N1, those kind of nomenclature. Where do we send a person who has been exposed to that bird flu that gets very sick? It's going to be the same Ebola assessment treatment facilities that we're doing the work for right now, okay? Because the first case of avian influenza, it's never gone from a bird to a human in the United States. We're the first state to have it. Now it's in Montana, Idaho, Oregon, California. But the first human case that comes, that hospital that's going to take that person in is going to have isolation. They're going to have PPE and training. They're going to have to handle the media and the fear. They're going to have this whole issue worked out with their staff. It's the same things we're talking about with Ebola. Science is a little different, but the principles are the same. This is why I really care about Ebola. It's not so much Ebola. I think Ebola is going to go away, to be honest. It's the next one, and the next one, and the next one that we have to be ready for. MERS, SARS, avian influenza, anthrax, swine flu, bird flu, pandemic flu, you name it. It's just not going to stop. So when we initially talked about what type of preparedness do we need in Washington State for any novel infection that's new and scary, is we really should have the ability to have everybody, that's in the outpatient and ambulatory care settings, be ready to identify, to isolate, and then transfer those patients. That looks so smooth, it looks so clean, it's this great little box. You can even make a flow diagram out of this. But what this really means is, does every provider really feel comfortable to know the risks of Ebola and the symptoms of Ebola? They missed it in Texas. What's to say they're not going to miss it here in Washington State? So how much work does it go into making sure every medical provider knows how to identify these cases? Even things, you guys, as simple as measles are very hard to diagnose. They look like other things when they come through the door. So being able to identify and then being able to isolate. And isolate's easy, but feeling comfortable isolating it. I had this discussion in our tribal clinic as we were going through this. I said, okay guys, we all really need to be able to identify Ebola. Everyone's comfortable. We went through the science. I said, all right, one of us is going to isolate this person. What room are we going to put it in? Everyone's comfortable identifying the room. Who's going to be the nurse or the doctor that's going to do it? Nobody stands up. Everyone's like, no way. I'm not trained. I'm not comfortable. So when we say simple things like safely isolate, there's a lot of work behind that. That's a lot of training. That's a lot of science. That's a lot of fear to overcome. And transferring patients. And I know there's someone on the group from EMS or from the Healthcare Coalition that's going to talk about transport. This, as much as we keep going over this and we keep being clear about how an ambulance or AMR or local folks are going to transport, this falls down almost every time, okay? So as much work as we can do and make this as important as this and this, okay? All that listed in a nice little bullet talk that I've been given for 6 months, and everyone reads it and we're all happy, but those are really complex issues right there. And it's not just specific to Ebola, it is for every new disease that's going to come along. So when we initially started this, there were a couple things that happened. The CDC told us every single provider has to be ready to identify and isolate and get this person transported. I think people are backing off that a little bit. They're backing off of two things. They're backing off this concept that everyone that comes through the door needs to be asked if they've been to West Africa. Okay? This is a very gray issue, but I'm going to say very black or white today. The 2 a.m. notice that I got from the CDC reversed a little bit of language and said everyone needs to be ready to identify the symptoms of Ebola, and in those people with those symptoms, ask whether they've traveled to West Africa. Okay, there's a couple of you in this room that know that I'm saying this just for you. Okay, so the other thing that they've backed off on is this notion that every provider should be able to identify, isolate for 24, 48 hours and test and then wait for the test to come back. We're moving much more, at least now, to this concept of having assessment facilities. Facilities that are clearly trained, capable, comfortable, and can prove that they can do all these things for short terms. Short term means what? 96 hours. Okay, 96 hours is a long time to hold someone. And I can tell you with the first Ebola patient that we tested a patient for Oregon. And lots of things you learn from every time you go through this. First thing we learned was this person was being monitored through the protocol we talked about in Oregon. And when the ambulance came to take her because she had a fever and she was African, so she's pretty clearly being monitored. When they came to pick her up in the full-on moon suits, what do you think the neighbors did besides freak out? Called the media. Okay, so the media is already they're following the ambulance. They follow it to the door. There's already media involvement in stuff like this. It sells papers, it sells time. They got there, by the time they could get her settled, get staff that were comfortable, get her isolated, and decide who was going to draw the blood, because that's a big fear still now. Who draws the blood? Who cleans the room? Who mops up the vomit? Is it the doctor or is it the nurse? Let's be honest. It's the nurse. So how comfortable were those nurses? That took, by the time they got their stuff together, and they've been telling me all day, hey, we got this patient, can you test for us? I get the public health lab ready to go. It was a good 24 hours before we got the specimen into the lab and we got testing, and it was a good 8 hours to get the test results back. So it's minimum 24 hours once you decide this is an Ebola suspect that you're actually going to get. So when we're saying that to frontline folks, can you really identify, isolate, and transfer? Can you really hold a patient for 24 hours? Do you really have the staff and the training? So that's the reason for the assessment facility. So we quickly started talking about, all right, which hospitals want to be assessment hospitals in Washington State? Okay? On top of which will be treatment facilities, who will actually be the hospital where you go to not only be maybe diagnosed, but actually taken care of, which has a lot of detail in it. How do we identify, isolate, provide ongoing care? How do we get adequate treatment areas, highly skilled and trained staff? So just think about the details. If a person, and I know Peg is going to talk about this later, just think about this. What hospitals want to take this on? Did it do anything good for the hospital in Texas that took this on? No. Okay, but fortunately we learned from their mistakes. There's a lot of training that can go on, but the concept was to get treatment facilities. So in Washington State, we have 3 treatment facilities. We have 3 hospitals that solidly stepped up to the plate and said, yes, it's our job. We are going to take care of Ebola patients like any other infectious disease. By the way, this is the same kind of argument we had when HIV came out. My colleagues going, I'm not taking care of an HIV patient. It's like, no, guys, if you're in the healthcare profession, you decided to take care of sick people. Suck it up, okay? 3 hospitals came forward and said, we are going to put ourselves out. That was Providence system. I got to tell you, in Washington, the Providence system has been the leader in this. They have, as an organization, a multi-hospital or multi-facility, have really stepped up. So Sacred Heart Medical Center, one of those treatment facilities. Harborview Children's Hospital. Okay, those are the 3 in the state that will handle an Ebola patient. So when an Ebola patient is actually identified and diagnosed, they will be transferred to one of those 3 facilities. So think about it for a minute. If you're a kid, that's easy. You're going to go to Children's. We're talking about what's the capability of Sacred Heart handling kids. But for now, we have a pediatric facility. Do you go to Harborview or do you go to Sacred Heart? Okay? And who makes that decision, and how do we get there? And quite frankly, the answer to this is it's going to be a discussion between the local health jurisdiction that has the patient, the local health jurisdiction, either Spokane or King County, where it's going, the hospital in both of those places where it's coming from or where it's going, and the transport system, if it's AMR or local EMS. We'll all be on the phone with the state saying, where are we putting this person? If Harborview is on, has a trauma, they're not going to go to Harborview. They're going to come here. What if Sacred Heart has something and they can't take the patient? They'll go someplace else, okay? We could still send them out of the state. But that's the concept, is 3 hospitals really stepping up to be those treatment facilities. We've had 8 or 9, and I say 8 or 9 not because I don't know how to count, it is that this changes every day. That hospitals that say they want to do it are now saying, oh, we can't, or we don't want to, or other hospitals saying, well, we may do it in the fall. But we have gone around to all 3 of these treatment facilities. CDC came out, we did assessments, we looked over, we gave feedback, and we told these 3 hospitals, you're ready to go. We're doing the same thing with these 8 assessment facilities. We are going around to each of them. We have gone to Swedish Issaquah, which is the first one we did. Well, actually, Providence Everett has already done it, so they're ready to go. And we have done Swedish Issaquah, which is a brand new hospital. And we are going to the UW Medical Center next week, and then we have a whole list after that, and I'll show you what that is. And then we are expecting, though, that all hospitals and clinics still have to screen and plan. You still have to be ready. And I'll talk about how this works well or not well in a minute here. So these are the 8 hospital systems that are stepping up. CHI Franciscan, that's Harrison Medical Center in Bremerton, okay? Serving the peninsula mainly. Providence Regional Medical Center Everett, serving the north of King County area, so north of Seattle up to the border. And then Providence Sacred Heart, which is obviously east side. Seattle Children's Hospital, mainly kids. Swedish Medical Center, again, Puget Sound area. This is Evergreen Hospital in Kirkland. UW, which has both Harborview and the UW Medical Center. So again, the Puget Sound area. Peace Health in Whatcom and Vancouver, although the Peace Health in Vancouver is not going to go forward right now. And then St. Mary's in Walla Walla. Okay, so that's how, think about that. Where are the holes? Where, if you're driving someone in a ground transport, is the biggest distance to be going? And I'll point it out. If these guys aren't up yet, and you are in Clark County, maybe you're going to go to Portland, or maybe you're going to drive all the way up to the nearest one, which is Harrison Medical Center in Bremerton. So there's a big hole out on the coast and in the southwest corner of the state. And again, nothing new to you guys in this area. You cover a large land mass where you have transportation issues that are unique. Okay. So the one thing to remind you is that the Ebola testing is done at the State Public Health Lab. This is one of the few labs in the country that has been validated. We have staff on call 24/7. Everyone has got their Category A shippers, and we've trained labs in local health jurisdictions to how to do this. I don't have, and this is in Shoreline, by the way, which is North Seattle. I don't have any concerns about our state's capability to do an Ebola test and do it quickly. My biggest concern is once someone decides to do the test, the biggest lag time will be getting that specimen drawn, packaged, and shipped to the public health lab in Shoreline. Okay, and we've actually tested 2 samples. We almost did one this last weekend, and I'm going to go through this for you because everything is really clean. We got frontline, we got assessment, and we got treatment. So here's what happened. I'm not going to give you the details of it. I'm just going to generic. There's this person who comes from Liberia, who comes through the East Coast, one of the 5 airports, with no symptoms. Okay, reportedly no symptoms. Gets put as a low-risk category in Washington State. We get a notice they're coming. We let the county know this traveler is coming, low risk, no symptoms, no fever, and they're designated as low risk. But he actually had abdominal pain, if it were a he. It could be a she, right? So he has abdominal pain. His sister says, "You're so sick, you need to go to the hospital. You can't come home with me from the airport." So they go directly to the hospital. Frontline hospital in County A. Did not alert the public health system. Okay? They got there and said, "Oh, wow, you have renal disease, you have renal failure, you really need ongoing renal dialysis." So pretty heavy duty, pretty bloody stuff, right? So they transfer him to Hospital B, but they don't tell Hospital B this is an Ebola person under observation. They just tell him it's a person that needs dialysis. So Hospital B takes the patient, not knowing that they're being monitored by public health in County A, who is now trying to find where is this patient. They find out they're in County B. So we've got local health jurisdiction in County A trying to track down a person in County B in a hospital that doesn't even know this guy's a traveler. So multiple things going wrong already, right? Oh, it gets worse, believe me. So he gets transferred. The critical care nurses do their job and they do an assessment and they go, "Whoa, wait a minute, this guy's traveled from Liberia and he has symptoms. Call the health department." By that time, which health department should really be leading the show here? Health department that they landed in, or the health department where they're sitting right now? And we haven't really had to wrestle with that issue very much, okay, but it's a real issue. Let's just say this county health department didn't know about this patient. This county was monitoring it. And someone in this county said, dang, you know, I know he doesn't have a fever, but he's got abdominal pain, and end-stage renal disease sometimes doesn't mount a fever. We should do an Ebola test, or we should consider an Ebola test. In the meantime, County B nurses hear from County A, patient is low risk with no symptoms, don't need to test, just use standard precautions and put him on dialysis, which is what they do. Later in the afternoon, when County A suggests maybe we should test him for Ebola, they get this county excited, and then the state gets involved. We're like, whoa, let's talk to the CDC. We all get on a conference call Saturday night, and it's decided, yeah, let's test this person for Ebola. So now the nurses in Hospital B hear, oh, remember when we told you don't need to worry about Ebola? Now we're going to test. And by the way, you need to step up your PPE until we get the test results back. That's a mixed message, okay? So, as smooth as things go, County B, now in the picture with Hospital B and the state, we're all talking and we're all deciding we're going to test this patient for Ebola because they have abdominal pain, no fever, no vomiting, no diarrhea. Remember those things I showed you at the front? Things that are really, is this person infectious if they're afebrile? So should we be testing this person? Okay, but in hindsight, it's a lot easier to judge. What happens is Hospital B says, okay, if we're going to test this patient, we're not an assessment facility. You need to transfer them to an assessment facility. Okay? How well did that go? Hospital B at 9 o'clock at night tries to get a hold of public health in County C, and they cannot get a hold of them. Okay? They never got a hold of the health officer. So in the middle of the night, County C, a couple things says, the hospital in County C says, yeah, well, we're an assessment facility. We're not taking this patient until we hear from the health officer in our county saying that we're going to do it. And they can't get the health officer. Not only that, and I'm still dissecting this, they could not get someone to transport the patient from Hospital B to Hospital C. It wasn't this nice diagram we have. It wasn't this nice matrix about EMS transport that we've all made. They couldn't find someone to transport from Hospital B to Hospital C. And so Sunday morning, I get a call, and I always hate when the phone rings at 7 on a Sunday morning, because you know someone's been sitting in bed since 3 going, when's it too early to call? And you know 7's kind of the magic hour. And so I pick up the phone. And I hear about this mess, not in County A. Hospital A didn't share it. County B is really upset. Let's just all get on the phone, all of us. CDC, Hospital A, Hospital B, Hospital C, County A, B, and C. We get on the phone, and I bring up a couple things. This person does not have a fever. So why are we testing him? He's from Liberia. Liberia has not had a case of Ebola in a long time. It's starting to go away in Liberia. He has not had direct exposure to an Ebola patient. So where is he going to get Ebola? Yes, he has abdominal pain, but it's explained by his abdominal pain from his end-stage renal disease. He's done well overnight. He's not febrile. He's not having vomiting. He's not having diarrhea. Let's not test. Okay. Sounds reasonable, rational. What does the nurse at Hospital B hear? You don't have to worry about it. Later in the evening, you really got to worry about it, and we got to transfer this patient, and oh no, we're not going to test. Even though we talk about the system, that I go through all the detail and it's all nice and clean, these things are a mess, okay? And we have to be better at this, okay? So even though I talked to you about all the work we've done, when you really do it, it gets a little messy. What happened to this patient, by the way, he remained afebrile, his abdominal pain went away. It is all really due to his end-stage renal disease, and dialysis actually helped him out. But we did not create a lot of friends with Hospital B or Hospital C, and these 3 counties are struggling on how we're going to make this happen, and why could we not get someone to transport a patient, because we thought we had this all worked out. Okay. Any questions at all about anything that Washington's doing? By the way, we are going back. I am talking to everyone involved. We're going back to learn some lessons from this. I did apologize to the hospital, even though it's not my fault, to apologize that puts you in a very uncomfortable position. This hospital did continue to hold the patient. They had by the way, these are all part of the same system, which made it at least nice. They had an internal discussion about best placement for this patient, and they remained at Hospital B. Okay? Trying to do any of this work before you get your first rule out in Spokane will be very helpful. Okay. And with that, unless there's any questions, we'll end there.